Hello, my name is Adrianne Adamson, and I am a Doctor of Nursing Practice student at the Catherine McCauley School of Nursing at Maryville University. Today, I am proud to present my DNP scholarly project titled Standardizing Rural Emergency Care, a Quality Improvement Initiative for Nurse-Driven Diabetic Ketoacidosis Management. This quality improvement project focuses on optimizing treatment of diabetic ketoacidosis in resource-limited emergency setting to enhance patient outcomes, reduce time to critical treatment, and empower nursing staff through evidence-based practice. In rural health settings, every minute saved during the initial stabilization of an endocrine emergency directly influences patient trajectory and safety. By establishing standard operating procedures driven by nursing leadership, we aim to bridge the gap between rural resource constraints and evidence-based acute care. Before we begin, I would like to express my deepest gratitude to my scholarly project committee for their guidance, clinical expertise, and academic support through this journey. My committee is chaired by Dr. Jessica Bland, whose guidance was foundational to the structuring of this study. Serving as my second reader and course faculty is Dr. Sarisa Moore, who was provided essential feedback on data analysis and formatting. Lastly, my community member and key clinical liaison is Emily Shoup, MSN, whose operational insight and facility coordination made implementation possible. Their mentorship has been instrumental in shaping this project from inception to evaluation. To provide context for this project, rural hospitals face unique structural and clinical challenges compared to tertiary centers. Patients presenting to these rural hospitals with diabetic ketoacidosis, or DKA, frequently experience delays in treatment due to variable provider availability, staffing constraints, and a lack of standardized ordered sets. On-site provider coverage in critical access hospitals can be intermittent or shared across units. Dedicated specialty teams or specialists are rarely available on-site, and without automated or nurse-driven protocols, laboratory testing and initial fluid resuscitation must wait for individual provider orders. DKA is a life-threatening endocrine emergency characterized by severe hyperglycemia, metabolic acidosis, and ketonemia. Timely treatment with fluid resuscitation, electrolyte rebalancing, and insulin administration is critical to preventing adverse outcomes. Delays in care increase the risk for severe complications, including severe hypokalemia, or cardiac dysrhythmias, acute kidney injuries, prolonged intensive care stays, and rare but fatal cerebral edema. Unnecessary transfers to tertiary centers place financial strain on patients and families. Through transport costs and displacement, the closest tertiary center to this facility is 90 miles. Furthermore, it strains local EMS resources when ambulances are tied up during multi-hour transfers. When rural facilities can safely manage uncomplicated DKA locally, tertiary beds remain available for higher acuity trauma or surgical cases. A comprehensive literature review was conducted to synthesize existing evidence on DKA management and the utilization of nursing protocols. The literature consistently highlighted three major themes. The first one, standardized clinical pathways for DKA significantly reduce hospital length of stay and accelerate the time required to achieve glycemic and metabolic stabilization. Second, the nurse-driven protocols have been proven highly effective in reducing door-to-treatment times, enabling early IV fluid administration, and facilitating rapid ordering of labs before provider examination. And third, the synthesis of literature emphasizes that successful adoption of complex nurse-driven protocols relies heavily on structured nursing education, hands-on clinical simulation, and continuous feedback. Protocol adoption succeeds when paired with hands-on training, clear flow charts, and ongoing feedback loops. Although nurse-driven protocols are widely studied in tertiary academic medical centers, a noticeable gap in the literature remains regarding the feasibility and long-term impact of protocols tailored to small rural critical access hospitals, where provider coverage and specialist consultations are often delayed. This project was guided by the Iowa model of evidence-based practice to promote quality care. The Iowa model provides a practical pathway for putting research into practice at the bedside. The process began with a knowledge-focused trigger, identifying clinical practice variability and delays in DKA care within my rural facility. Following an extensive review and critique of research evidence, the decision was made to pilot a nurse-driven DKA protocol. Key steps included drafting standardized order sets, delivering staff education, and integrating the protocol into the electronic medical record. The implementation was continuously monitored through process audits, confirming that the protocol aligned with the hospital's safety and patient retention goals. Following the post-implementation review, the protocol was adopted permanently into the facility's policies. A pre-implementation versus post-implementation quality improvement design was selected for this project. The design allowed for a direct comparison of baseline retrospective data with post-implementation outcomes. The intervention comprised two primary cohorts. First, the development and integration of a standardized evidence-based nurse-driven DKA protocol, guidelines and standing orders for laboratory evaluation and initiation of 0.9% normal saline infusion were included in the protocol. There was also clear criteria for notifying a provider before initiating insulin. Secondly, interactive educational sessions for all nursing staff focused on DKA pathophysiology, fluid resuscitation calculations, and protocol execution. The QI design was chosen as the most appropriate methodology because it directly measured the process for efficacy, clinical adherence, and workflow optimization in real-world clinical practice without delaying patient care. The setting was a rural critical access hospital serving a population with limited access to specialty care. The target population included all adult patients aged 18 to 95 who presented to the emergency department and received a clinical diagnosis of diabetic ketoacidosis. Data was collected across two distinct cohorts. The pre-implementation cohort served as the baseline control, and the post-implementation cohort followed protocol rollout. Descriptive statistics were utilized to characterize the samples across the two cohorts. There were no statistically significant demographic differences between the pre- and post-implementation groups, establishing baseline comparability. To evaluate the efficacy of the protocol, we analyzed a sample consisting of pre-implementation baseline patient charts alongside post-implementation participant data. Descriptive statistics were utilized to characterize the sample in terms of age, diagnosis, and disposition. Both cohorts were statistically comparable in the initial disease severity, ensuring that observed post-intervention improvements were driven by the nurse-driven protocol rather than underlying differences in acuity. The total sample size ended up being 18, with the pre-intervention group being 13 and the post-intervention group containing 5. The data analysis focused on two main clinical variables: patient disposition and diagnosis type, specifically comparing patients who were admitted locally versus those transferred to tertiary centers, and patients with a primary versus secondary diagnosis of DKA. Due to the limited sample size, we could not run a test such as the chi-square test to evaluate statistical significance. The descriptive analysis framework allowed assessment of how standardizing care affected disposition decisions and whether treatment effectiveness varied by diagnostic acuity. This slide highlights the core project findings displayed in the charts. First, analyzing patient disposition revealed a clear shift. Before protocol implementation, a higher percentage of DKA patients were transferred to a tertiary center. Following protocol implementation, a higher proportion of uncomplicated primary DKA patients were safely stabilized and admitted locally, reducing unnecessary transfers. Pre-implementation, 100% of the patients with DKA were transferred to tertiary centers. Post-implementation, only 80% of the patients required transfer. The pie charts analysis showed that 20% of patients with the primary DKA diagnosis were successfully stabilized and managed in-house under the new protocol. 80% of the patients were diagnosed with secondary DKA and required transfer to tertiary facilities due to complex underlying comorbidities, such as concurrent sepsis, acute coronary syndrome, or acute renal failure that required dialysis. Every quality improvement initiative in a rural critical access hospital encounters unique contextual limitations. This project yielded positive outcomes, but several limitations must be acknowledged. First, the project was conducted within a single rural facility, resulting in a small total sample size of just 5, 18 overall, which limits the generalizability of the findings. The overall baseline incidence rate of DKA presentations in a low-volume rural critical access hospital contributed to the small sample size. Second, the time window for post-implementation data collection was constrained by the academic schedule, limiting the ability to evaluate long-term sustainability. External confounding variables such as nursing turnover, agency staffing, and varying daily emergency department patient volumes may have influenced workflow efficiency. To mitigate these limitations, standardized visual flowcharts were created and available to assist with execution of the protocol by all staff members. Recognizing these limitations provides valuable context for interpreting our results and planning for future clinical expansions. In discussing these findings, this project clearly demonstrated that empowering nurses through standardized protocols bridges the care gaps in rural health settings. By eliminating unnecessary delays in provider orders for standardized diagnostic and initial stabilization measures, nurses can rapidly initiate life-saving interventions. Standardized order sets streamline expectations between nursing and providers. These results directly answer our core practice inquiry. A nurse-driven protocol not only shortens treatment delays, but also fosters a culture of nursing autonomy and clinical confidence. These findings align closely with prior literature from larger tertiary academic institutions, confirming that quality improvement methodologies for protocol initiations can be successfully adapted to small, resource-constrained rural critical access hospitals to elevate standards of care. Implications of this scholarly project extend across multiple levels of the healthcare delivery system. For clinical practice, it establishes a sustainable and standardized clinical workflow that optimizes the nursing scope of practice. For patients, particularly those in underserved rural communities, it ensures faster, safer, and higher quality medical interventions during critical metabolic emergencies such as DKA. From an organizational and health systems perspective, expediting DKA stabilization in the emergency department helps streamline patient flow, reduces length of stay, and minimizes unnecessary hospital transfers to tertiary centers. This quality improvement project serves as a reproducible model for other rural hospitals seeking to standardize management of DKA. This framework could be used to expand nurse-driven algorithms for other acute presentations in rural facilities as well, such as hyperosmolar hyperglycemic state or severe hypoglycemia. In conclusion, the successful implementation of this nurse-driven DKA protocol highlights the transformative impact of evidence-based quality improvement in a rural critical access hospital. Standardizing DKA care through a nurse-driven quality improvement initiative in a rural critical access hospital effectively reduces treatment delays, increases local admission capacity for primary DKA, and ensures safe transfer decisions for complex secondary DKA cases. Reflecting on this project, if I were to repeat this initiative, I would expand the interprofessional training component prior to rollout by involving pharmacy staff to help streamline automated dispensing cabinet overrides. This would help for the protocol-driven lab and fluid orders. Looking ahead, my future plans involve advocating for regional adoption of this standardized nurse-driven protocol across neighboring critical access hospitals. On a personal level, completing the Doctor of Nursing Practice program at Maryville University has been transformative. My approach to clinical practice has been equipped with advanced knowledge in system leadership, translational science, and quality improvement methodology. As a DNP prepared scholar, I have gained the skills and vision necessary to identify gaps in clinical care, lead interprofessional teams, and champion health equity and quality care for vulnerable and resource-limited communities and facilities. This concludes my presentation. The complete list of peer-reviewed literature, clinical guidelines, and frameworks referenced throughout this project and presentation is formatted in accordance with the current APA guidelines and displayed on this slide and in the submission notes. Thank you very much for your time and attention. I look forward to answering any questions.